Hi, we start second lecture about NAPLEX and USMLE exam review. This course is related to pharmacology. We review the therapeutics, and the second lecture is also about cardiovascular disorders. We started hypertension last lecture with thiazides, and we continue these lectures with the beta blockers. Beta blockers, also known as a beta-adenosine blocking agent. First, I start from the cardiovascular disorder. As you remember, the main problems in the cardiovascular disorders is hypertension, dyslipidemia, heart failure, and ischemic heart disease. And mainly, in the pharmacology, we try the treatment of these types. We continue hypertension. The first, we start with the beta blockers. Beta blockers, also known as the beta-adenergic blocking agents or beta-adenergic blockers drugs, are medications that reduce blood pressure. They can work by blocking the effect of hormones, epinephrine and norepinephrine, or adrenaline and noradrenaline. And when we take a beta blockers, heartbeats decrease and the heart force, contraction force will be also decreased. And this can be effect for decrease the blood pressure, because the blood pressure effect can be controlled by cardiac output and heart rate. Beta blockers inhibit adrenergic response through the beta receptor. In this main situation, first we have to know what is a beta receptor. Beta receptor is the membrane, transmembrane receptors, which ligands cannot go inside the cell and affect in the outer side of the cell membrane. And the beta receptor are subfamily of the adrenergic receptors, and these receptors mainly works with G protein, is belong to the G protein coupled receptor family. Mechanism of action. As I explained, the beta blockers can blocking the effect of the epinephrine and norepinephrine. In this situation, reduce cardiac output by negative inotropic effect in the heart, reduce contractility, and the negative chronotropic and reduce heart rate. And cardiac output and the heart rate, mainly to goal of the control of the hypertension. And we have several types of the beta blockers which we study today. Cardiovascular beta blockers bind to the beta 1 more than beta 2 receptors at a lower dose, and the cardioselectivity may be lost at higher dose. But at first I explained about the beta blockers types, and before it I start to explain beta receptors. We have three types of the beta receptors. The first is beta 1 and beta 2 and beta 3. Beta 1 mainly we can find in the heart and also in the eye and the kidney, and the beta 2 we can find in the lung, vessel, and other glands also. As you see, we have a beta 1 adrenergic receptor, beta 2 adrenergic receptor, and beta 3 adrenergic receptor. As I explained, beta 1 adrenergic receptor is the subfamily of the G protein coupled receptor. We have a different type of G protein coupled receptor types. First one is the GS. Beta 1 is belong to the GS. It is a heterochromic G protein As you see in the photo, G-protein coupled receptor has several parts: transmembrane protein, alpha subunit, beta subunit, and gamma subunit. When the ligand binds to the G-protein coupled receptor, GTP binds to the alpha subunit. Okay? In this situation, because of the conformation change, alpha, beta, gamma separate from each other. Okay? And alpha goes to the bind to the other enzyme which is called adenylyl cyclase and activated this enzyme. In this situation, ATP can convert to the CAMP, and because of this situation we can say which stimulates CAMP dependent pathway by activation of adenylyl cyclase location in the postsynaptic membrane of the heart with Ming. In heart, beta 1 receptor, when the adrenaline or noradrenaline bind, it has a positive chronotropic, positive dromotropic, positive entropic. But we also can find this beta 1 receptor in the salivary gland and increase amylase secretion from the gland. And second beta receptor is beta 2 adrenergic receptor. It's also GS heterotromic glycoprotein, and it is also a subfamily of the GS, is a subunit, and also the same mechanism. It has alpha, beta, gamma, and the GTP bind to the alpha subunit, and then alpha, beta, gamma separate from the receptor, and alpha subunit go bind to the adenylyl cyclase and activated it, and then adenylyl cyclase can convert ATP to CAMP. Location is the same in the postsynaptic membrane of the isthmus muscle and gland, not heart. Then it can cause isthmus muscle relaxation, mainly in the lung also can affect bronchodilation, blood vessel vasodilation, and the uterus can be have a relaxation. But in the gland, also beta 2, we can find in the kidney for the renin secretion, for the pancreas, insulin secretion, and in the liver, gluconeogenesis and glyconeogenesis. Beta C adrenergic receptor mainly we can find in the adipose tissue and the bladder. It can regulate the lipolysis and thermogenesis in the adipose tissue. Main mechanism is the GS heterotromic G protein. The first group of the beta blocker we start to study today is the cardioselective groups. The cardioselective groups mainly in the lower dose affect in the heart and mainly affecting the beta 1. And the first group of these drugs is Acebutolol, Atenolol, Betaxolol, Bisoprolol, and Metoprolol. Acebutolol, in the brand name we can find in the United States or other countries with the Sectral name, and Atenolol we can find in the brand of Tenormin, and the Betaxolol, the brand is the Kerlone, and the Bisoprolol is the brand is the Zebeta, and the Metoprolol we can find in the two type of the salt is the tartrate and the succinate. In tartrate I can mention Lopressor, we use mainly 2 times a day, and succinate salt is a Toprol XL, which we can make 1 time a day. The first medicine is the Acebutolol. Acebutolol, dose of the drugs between the 20 and 50 milligram per day. We can find with the capsule in the oral form, and it has a hydrochloride form. It is a competitively block beta 1 receptor with a little effect on the beta 2 receptor, except at higher dose. As I mentioned, at higher dose, cardioselective also affecting the beta 2 receptor. As I mentioned, the normal dose is between 20 to 50 milligram per day. Metabolism is the extensive first pass effect, okay, and equipointed and the cardioselective diacetolol metabolites, and in this situation the metabolite also has a cardioselective effect. Absorption is around 40%, and excretion we can find the feces because the absorption is lower. In the urine we can find around 30 to 40% in the diacetolol, which is the metabolite forms, and we can find in the urine. Duration action is around 12 to 24 hours. The protein binding is lower, and the half-life elimination of the drugs which eliminate by the kidney for the parent drug Acebutolol is around 3 to 4 hours, and for metabolites is around 8 to 13 hours. And for this situation, and the duration action is high because of the half-life elimination of the metabolites is very slow. Important renal function impairment, because as you know, the elimination of these drugs mainly in the kidney and decrease the elimination of the diacetolol, resulting in the 2 or 3-fold increase in the half-life. Special populations we can mention the elderly. And second group of cardiovascular beta blockers are Atenolol. Absorption is in oral is rapid but is incomplete because around 50% of this drug is absorbed. Distribution, because of low lipophilicity, does not cross the blood-brain barrier, then we don't have any dizziness or any CNS side effects. Metabolites mainly. With the lower limited hepatic metabolites, we have excretions 50% excrete in the feces because of the non-absorption, and in the urine we can find 40% in the unchanged drugs. Protein binding is very low, it's around 6 to 16%, and normally we have as I mentioned, in the bronze we have a Tenormin, and we have a 25 milligram, 50, 100 milligram, and in generic also we can find these amounts. The second drugs of this family is the Betaxolol. Betaxolol is absorption is 100%, and because of this we normally use 5 to 20 milligram per day, and the metabolism is hepatic to multiple metabolites, okay, and also the metabolites of this drug also has a cardioselective also effect in the beta blockers. Excretion urinary in the 80%, and the 15% is unchanged or in the inactive metabolites. Fourth drugs of these groups are Bisoprolol. Bisoprolol, like Betaxolol, is rapid and almost complete absorption, and brands is Zebeta, and the dose of the drugs is between 2.5 and 20 milligram per day. It has a extensive hepatic metabolism, and it has a significant first pass effect when the drugs absorbed from the GI tract by the portal circulation. It goes to the liver, and in the first pass effect the drug can be metabolized. Excretion, urine excretion 50% because unchanged drugs, and the remainder is inactive metabolism, and very low amount in the feces we can find. The last drug of this family is the Metoprolol. Metoprolol is the lipophilic and can cause CNS side effects like depression and fatigue. Absorption is rapid and complete. Distribution is around 3.2 to 5.6 and cross the blood-brain barrier. And CSF concentration can be high, 78% of the plasma concentration. Metabolized extensively hepatic, metabolized by enzyme CYP2D6, and significant first pass effect. Excretion usually by the urine system 95%, and which 10 to 5% is without change and increase to 30 to 40% in pool CYP2D6 metabolizer enzyme. It can be happen because of the drug interaction and which can affect for this enzyme. Primary side effect mainly it has a bradycardia. As I mentioned, beta blockers reduce heart rate, and this drug can cause bradycardia, and it has heart block, and it also affects in the heart failure disease. And in this situation we have care about these groups, because in the heart failure we have to meterize beta blocker, and we cannot use every beta blocker for the heart failure. Normally it can cause bronchospasm, usually in the higher dose, and it can cause cold extremities. Lipophilic beta blocker can cause fatigue and depression, and these groups, the main primary side effect for the diabetes mellitus patients is the glucose intolerance, because it can cause mask of hypoglycemia. We continue with contraindication. As I mentioned before, beta blocker cannot be prescribed to patients with recent or current history of the fluid retention without concurrent diuretics use. Beta 1 blocker are contraindication in the patient with complete heart block. I mentioned should be used with a great caution the patient with a heart failure and with second degree of heart block. Beta blocker, first beta blockers, beta blocker 1, generally are contraindication in the patient with moderate to severe asthma. And as I mentioned, the side effect, and the patient with chronic obstructive pulmonary disease can be dangerous for them. In the heart failure, as I mentioned, the side effect, we cannot use beta blockers, and just in cardioselective we can use Bisoprolol and Metoprolol. And the key monitoring, we have to care about blood pressure and heart rate, because it can cause bradycardia and it can decrease the blood pressure to so lower. And we have to care about heart failure, and also we have to control the blood glucose, because it can affect in the glucose intolerance and mask hypoglycemia in the patient. And for the drug interaction, digoxin and the verapamil or other drugs which have a negative effect in the heart rate, like digoxin, verapamil, can increase the risk of the bradycardia. And we have to care about the heart rate. When we use two groups of the drugs for the decrease of the blood pressure, we have to care about the heart rate also. I start with the second group of the beta blockers, non-selective. Non-selective beta blocker like Carvedilol, Labetalol, Nadolol, Indolol, and Propranolol, which is very famous, and Atenolol. Carvedilol, in the brand name is the Coreg or Coreg CR, and the Labetalol, the brand name is the Trandate, and the Nadolol, Corgard, and the Indolol, brand name is the Viscan. And for propranolol we can use Inderal and InnoPran, and for Tenormin we use Blocadren. The first drug of this family, non-selective beta blockers, it is Carvedilol. It is a lipophilic and can cause CNS side effects like depression and fatigue. Absorption for this drug is rapid and extensive. And these drugs, because it is lipophilic, with food the absorption can be effective, and it has a high fast first pass effect, because it has a two type of esteroselective types with first pass effect in the esteroselective with R positive enantiomer, which is plasma concentration higher than S negative enantiomer. As you know, in the organic chemistry we have a two type of the estero enantiomers, R and S. And the metabolism of this drug, extensively 98% of this drug can metabolize in the liver. by enzymes CYP2D6 or 2C9 or 3A4 or 2C19-1A2 and 2E1, and metabolized by aromatic ring oxidation and glucuronation, and oxidative metabolism by the conjugation via glucuronation and sulfation. Three active metabolites, which 4-hydroxyphenyl metabolites, is more potent than the parent drugs, and the effect for the heart is more than Carvedilol. And the first pass effect, plasma concentration in the elderly and those with cirrhosis liver is higher. And the metabolism is subject to the genetic polymorphism. CYP2D6 poor metabolizer have to 2 to 3-fold higher plasma concentration of the R plus enantiomer, and 20 to 25 increase in this S negative enantiomers compared to the extensive metabolizer. In this situation, the enantiomer of these drugs also the metabolism can be selective. And the second drug of this group, Labetalol, it is a lipophilic and can cause CNS side effects like depression and fatigue. Absorption is complete because it is lipophilic, and the metabolism mainly in the hepatic and mainly by glucuronide conjugation in the metabolism in the liver. Extensive first pass effect in this situation. The concentration of the dose of this drug we need around 200 to 2,400 milligram per day because of the high first pass effect and the metabolism. Excretion urine with 60% as glucuronide conjugation, and the low dose unchanged drugs because mainly it absorbed completely and also can because of the bile secretion. So the third drug of this group, it is Nadolol. Nadolol has a low absorption around 30%, and it has a hydrophilic, and the metabolism is not metabolized, and excretion usually in the urine as an unchanged drug. As you see in this picture, because of the low absorption, also low metabolism or not metabolism, in this situation, Nadolol can be used in the very low dose to higher dose, from the 20 milligram until 320 milligram. Pindolol, the next drug of these groups, is a lipophilic, can cause CNS side effects like depression and fatigue. Absorption is almost complete, rapid because it is lipophilic, and it has a metabolism around 60 to 70% by the liver. It is a hepatic to conjugation system. Excretion in the urinary 35 is as an unchanged drug, and 65% can be as a metabolism form. And also we can find the feces because of the bile duct secretion, and also part of the drugs which cannot be absorbed. Propranolol is a famous drug of this group, is lipophilic and can cause CNS side effects and like depression and fatigue. Absorption is rapid and complete, and the metabolism is extensive first pass effect, metabolized to active and inactive compounds. Three main metabolized pathways. The first one is aromatic hydroxylation, primarily 4-hydroxylation, and the alkylation. These three metabolism is very important because of the ring, aromatic ring, and also the alkyl groups, and also side chain oxidation and direct glucuronation. Excretion metabolites are excreted primarily in the urine, 99%, and less than 1% can be in unchanged drug form. Propranolol dosage or dose per day normally is 80 to 640 milligram per day in the IR, the 80 to 640 milligram per day in the ER. And it's very important, these drugs is we can use these drugs in the anxiety also, because in the anxiety and depression with a higher heart rate, these drugs can be more effective. And the last drug of this group, Tenormin, it absorption is rapid and complete. Metoprolol extensively hepatic metabolized by enzyme CYP2D6, and it has extensively first pass effect. We can use for the glaucoma in the eye, and excretion normally with urine and feces, and mainly we use in the ophthalmic agent as anti-glaucoma. The side effect is the same of the selective beta blocker, cardioselective beta blocker, and non-selective beta blocker should be avoided in the patient with asthma and reactive airway disease, because this mainly can be affecting the beta 2 receptor, and the beta 2 receptor is very dangerous in the asthma patient. Okay, and also I mentioned for the beta blocker we have to care about dosage, and we have to care about heart rate and blood pressure, and contraindication the same as the cardioselective. I mentioned in the cardioselective, but for the heart failure, just we can use the Carvedilol from these groups. Monitoring is the same. We have to care about blood pressure, heart rate, and we have to care about heart failure, and also because of the intolerance and the mask hypoglycemia, we have to care about these drugs. And also related drug interaction, have to care about heart rate, and some of the drugs can be caused bradycardia with these groups like dioxin and verapamil. For systolic heart failure, I mentioned for heart failure, we cannot use these drugs. We mainly use beta blockers, Metoprolol and Atenolol and Carvedilol for the systolic heart failure. Some of the beta blocker has ISA effect, which has a partial beta receptor agonist activity like Carteolol, Acebutolol, Pindolol, and Penobutolol. Penobutolol we didn't see in the last slides, is a beta blocker and bind to the both beta 1 and the beta 2 adrenergic receptor, and it's a non-selective beta blocker. Penobutolol can act as a partial agonist at the beta adrenergic receptor, since it is a sympathomimetic drugs. And Penobutolol also high binding affinity to the serotonin receptor 1A with antagonist effect. In this situation, in the depression, it is very important. We have to care about anxiety and depression. This binding characteristic of the Penobutolol is being investigated for the implication in the antidepressant therapy. Penobutolol is contraindicated in patients with cardiogenic shock, sinus bradycardia, and second and third degree atrioventricular conduction block, and bronchial asthma, and also hypersensitivity. As I mentioned before, the second drug which has a ISA effect, it is a Carteolol. Is a beta-adrenergic antagonist used as an anti-arrhythmia agent and anti-angina agent, and also we can use anti-hypertensive, and in the drops we can use for the anti-glaucoma. Here is the table for the clinical use of all of these drugs. As you see in this list, for the hypertension, almost we use all of these drugs except sotalol, which is a non-selective beta 1 and beta 2, and we use sotalol. We will study in the arrhythmia part, anti-arrhythmia drugs. We use mainly for the anti-arrhythmia. And we will study later for the angina. We use almost all of the drugs except Carteolol and Carvedilol, also Esmolol and Nebivolol. Nebivolol is very good drugs for the hypertension, and this drug is only drugs mainly prescribed for the hypertension. And for the arrhythmia, we can use some of these beta blockers like Nadolol and sotalol and Timolol. But Timolol we can use also for the glaucoma. for myocardial infarction, we can use just Nadolol and Propranolol and Timolol, which also we use for glaucoma, and Atenolol and Metoprolol. But for the chronic heart failure, I mentioned before that for the heart failure, we use just Carvedilol and Bisoprolol and Metoprolol. Also, we can classify beta blockers in the generation. We have 3 generations of the beta blockers. The first generation usually is non-selective beta blockers, which affect for the beta 1 and beta 2 receptors. And we have to care about the asthmatic patient and lung disease problems and the disorders in the patient. In the second generation, we have beta 1 selective groups, which these groups mainly affect just in the heart in the low dose. And if we monitorize this group of drugs, we can use for the patient. And the last third group, third generation, main effect is the vasodilatory. It can be non-selective and beta 1 selective. In the beta 1 selective, we use mainly now Nebivolol, which has a vasodilatory without effect in the nitric oxide, or Betaxolol. And for non-selective vasodilatory effect, we can use Carteolol and Carvedilol and Labetalol. I hope this lecture was good hope this lecture is useful for our students, and we will continue the next lecture in the other subgroup of the drugs for the hypertension. I hope it will be good, and see you next time.